I had gone on vacation to Mexico. We were on spring break, sore throat the whole time, et cetera, et cetera. When we came back, I finally saw someone, and that specialist took one look when I opened my mouth, and he says, that's cancer. It's HPV-based cancer. We'll get a biopsy and whatever, but I've seen 100 of you a week, and that's what it is.
I mean, you're a journalist. You make your living with your voice. So when that specialist took one look and said, it's cancer, what kind of went through your mind?
You're reading my mind. I thought, oh, you got to be kidding me. I'm still being treated for prostate cancer.
This is Genetics for Healthcare, a podcast for patients.
This is Genetics for Healthcare, a podcast dedicated to helping patients and their caregivers to advocate for a precision medicine approach to treatment, survivorship, disease screening, and prevention. It is a great honor to share patient stories that will hopefully encourage and empower you to have better conversations with your caregivers, have these same conversations with family members. And I'm happy to have Emmy Award-winning broadcast journalist and anchorman, Steve Pickett, with us today.
Good morning, sir. How are you?
Unbelievable, Steve. First of all, I got to tell you, it's one thing to watch you every day. We're in the Dallas-Fort Worth area. Steve has had an illustrious career. You're watched by quite literally millions whenever you're on television. But getting to know your story that you're going to share with us today and our listeners, it is really an honor and a privilege to have you on.
Listen, I certainly do appreciate it, the opportunity to have this kind of dialogue, have this conversation. Frankly, to just remind everybody that regardless of lot in life, we're all pretty much in the same bucket when these things happen. And it's just because I think based on what I do for a living, there's a tendency for people to forget that we're just like everybody else. And I have certainly lived that over the last couple of years.
Yeah. Okay. So I want to start with actually how you got into journalism. Did you grow up wanting to be a journalist, or was it the draw to television? Tell us a little bit about that.
That microphone you have in front of you, that is the dream job for me. Ever since I was in the 8th grade, what I wanted to do, I loved radio and radio DJs. I would stay up all night long. My mother I'd get in trouble because she'd say, boy, turn that radio off, because that's all I knew. I was just fascinated with the radio, and primarily, as we called them back then, disc jockeys. So by the time I remember it well, in the 8th grade, I decided I was going to be a radio personality. And by the time, if you will, Rome, I was in the 10th or 11th grade. I'm now 63 years old, native Oklahoman. And we started parties. We would have teen parties, at community centers. And I was a DJ, and that's how it started for me. I am a first-generation college kid. My mother raised 4 of us, single-parent household. I'm the oldest of 4. And all I thought about back then was being on the radio, and I would do anything to be on the radio. And I would sit here and talk to you all day long about that journey, but it really started for me by volunteering at a radio station when I was 16, 17 years of age. And from that, I, decided I wanted to go to college because I realized that you probably needed to go to college. No one else in my family had gone to college and things of that nature, and went on to the University of Oklahoma. And the first place I went to at the University of Oklahoma was a place called Kaufman Hall that had KGOU radio on the 2nd floor. And I stood in line with a lot of our students wanting that opportunity my freshman year there. And they said, raise your hand if you've even been in a radio studio. And I had in high school begged this man to let me do high school sports. I would go out to do high school sports. And lo and behold, I got that opportunity at OU. And as they say, the rest is history. So I have been at this game, it transitioned from radio to news. I have done every job you could possibly think of in television. I started at the ABC affiliate in 1981 in Oklahoma City, buffing the floors. I was a studio production guy, and you buff the floors. You were taught how to run camera. And as we say, I've done every job. As a reporter, I eventually graduated from college, journalism degree, learned how to write. As you can see, I run my mouth, so that was the easy part of the job, to ask questions and talk to folks. And I went to Wichita Falls, Texas for my first job for a whopping $11,000 a year.
Wow.
And
the sacrifices we make.
Absolutely. And from there, I was offered a job in California. I worked there for 8 years, went to the NBC affiliate in Portland, Oregon for 3 years. And then I came to Dallas. I was offered a job at CBS, and I've been here now almost 29 years.
Wow. I haven't realized it's been that long since I've been watching you on television. So the career journey has placed you here in the Dallas-Fort Worth area. And as I've gotten to know you, you revealed to me that you've been dealing with a cancer battle. And even though we had similar circles of friends, we really didn't know each other on that level because you didn't know what I did with respect to cancer research and precision medicine. But can you walk us through your initial diagnosis and experience with cancer? Yeah,
it was a little over 2 years ago. And as I mentioned to you before, I'm I believe in going to get annual physicals. I believe in healthcare and taking care of your own health. And I would have my annual physicals. And we had seen where the PSA blood tests on your annual physical, those numbers starting to creep up. I'm 63 years of age. It wasn't anything out of the ordinary. I'd had a couple of episodes previously of prostatitis. But nonetheless, it was, I believe, the numbers. So I want to say October of 2022, when I had a physical, which included obviously blood tests, which included a PSA. And the PSA came back, I believe the number was a 9, and that was clearly an indicator of trouble. From that, I was sent to a specialist urologist who went through the protocols, et cetera, including a biopsy. And sure enough, I was diagnosed with prostate cancer in late 2022. Started being treated for that prostate cancer in 2023, which included several rounds of radiation. That was my course of treatment for us was radiation, and of course some hormone treatments, things of that nature, and have done relatively well on that. And then, of course, about a year later in March, late February, early March, I had a sore throat, and that turned into yet another cancer diagnosis.
Okay. So this is a period of time over a year that you initially diagnosed. And again, the key here is you were routinely going to the doctor. And so you were aware of kind of what was going on top of those things. So, well, let me ask you directly, was it a good outcome with your, prostate cancer care, your treatment?
As they say, so far, so good. Everything indicates that our regimen is working. My PSA shows 0, which is where they want it to be. And we've slowed down the treatment plan for that and just watch it and monitor it because of the very aggressive campaign on fighting the tonsil cancer I had. So we slowed down on prostate, but I have been very fortunate on the prostate regimen, on using radiation and, again, the meds. So it was definitely jarring, but not, if you will, not surprising to me, because I just knew that in this job, I've seen it all. And because of that, I think for me psychologically, my mindset was simply, okay, we have it. It's here. It's obvious. If you know your body, there are signs, there are indicators. I mean, particularly for men. And the thing about it, as you age, you have to pay attention to it. And that's what I was doing. I mean, I knew there were other things. There were, the frequency of going to the bathroom, not emptying your bladder, all those kinds of things. And again, because I had previously cases of prostatitis, the infection of the prostate, from physicals. I had gone back and said my lower back was tight, and I exercised a lot, and I couldn't figure out why my lower back was hurting. And literally, when I went in for a checkup, and when you get a prostate check, I mean, when they take you through that exam, I fell to my knees in pain. In that situation room, it was just antibiotics. They said, "Oh, it's just an infection," and it was. Cleared up. I was fine. Lo and behold, a few years later, we end up with prostate cancer. But the key for me was, I think more than anything, was being cognizant of understanding annual physicals and paying attention to those things.
And so a year plus when you start to develop the sore throat, what was kind of going through your mind then when you start having those symptoms?
This was, again, late February, early March of this year. And it was, we all have sore throats. Is there a virus going around? What have you? That kind of thing. But it wouldn't go away. That was the difference for me. You take cough drops or whatever. I mean, just basic stuff, and it wasn't going away. So I went to my practitioner, my general practitioner, my doctor. And from that, they looked at it and thought the same thing. It's just an infection, gave me antibiotics, et cetera, and it still was present. And I knew something, and I could see it. I could literally see what was defined as an infection on what I now know as my tonsil. We thought it was the throat, but I could see it. Open my mouth, look in the mirror, and I could say, "Whoa, what? That's it looks like pus or what have you." So I go back. I go back and say, "This is something different." And of course, those doctors referred me to ear, nose, and throat specialist. It took a while to get an appointment. That was one thing that was sort of frustrating, trying to find someone, get set up, et cetera. The clock is ticking in my mind, and so that took a while. And I had gone on vacation to Mexico. We were on spring break, sore throat the whole time, et cetera, et cetera. When we came back, I finally saw someone, and that specialist took one look when I opened my mouth, and he says, "That's cancer. It's HPV-based cancer. We'll get a biopsy and whatever, but I've seen 100 of you a week, and that's what it is."
Okay, so I mean, you're a journalist. You make your living with your voice. So when that specialist took one look and said it's cancer, what kind of went through your mind?
You're reading my mind. It was, I thought, oh, you got to be kidding me. You can't. I mean, I'm still being treated for prostate cancer. So I'm like, what are we talking about here? You got to be kidding me. Throat. And all I heard was throat cancer, the larynx or whatever, all that kind of stuff. And they're using this terminology. And I'm thinking, you got to be kidding me. How in the world do I have? In my mind, it was, how did the prostate cancer end up in my throat?
Yeah.
Because there was, this thing about prostate cancer was you really watch it because we don't want it to spread. One of the things they talk about is where prostate cancer spreads. They talk about bone cancer, things of that nature. No one said anything about throat, tonsil. And they said, first of all, number one, these are two separate cases. These are two separate things. And he reassured me. He said, also, I know what you do for a living. I know you need your voice and your throat. So we're going to talk about process, how we're going to, do this. Urologists are surgeons, just like urologists are surgeons. This ENT specialist also surgeon. And so, generally speaking, the first plan of action is cut cancer out. And of course, right off the top, he says, let's look at doing something else other than that. We don't want to get in there and affect your livelihood, which was, of course, my voice, vocal cords, things of that nature. But it really, once the biopsy came back, it wasn't, if you will, that deep. It was sitting on my tonsil.
Okay. Do you have a family history of cancer? Do you know of?
I say this, folks, in all sincerity, and then doctors say, well, then, yes, you do. Because I say, no, I don't have any history of cancer in my family, to my knowledge. Although I have a sister, it's four of us. My sister's the youngest, and she died 11 years ago from colon cancer. She was diagnosed with colon cancer, stage 4 colon cancer, survived for 3.5 years and died. And so that's the only cancer case I'm aware of in my family. And so my instinctive reaction is we don't have a family history of cancer. They would say today, oh, yes, you do, because your sister has cancer. But folks on both sides of my family, maternal and paternal, for the most part, we're impacted by diabetes, heart disease, things of that nature. I don't know of, I'm just not aware. And I've asked, and because she's my sister, that was the first case we saw in the lineage of at least 2 generations that I was aware of a cancer case.
The reality is for families in this generation, we don't know. We know that the prevalence of cancer has increased over the last couple of generations, but it was very common, at least in my family or families that I grew up with, that they wouldn't tell you that Big Mama had cancer. I mean, the C word back in the 70s when they refused to put labels on cigarette packages, like it was still up for the debate whether cigarettes cause cancer, but it was so taboo to even talk about cancer that many of us as a result don't know what Uncle Jones died from or Big Mama died from. So I guess I
That's right. That's right.
What was the mindset of family members toward even getting screened or having knowledge of a family history of cancer?
I quickly learned, I was not surprised, by the way, I was not surprised by it at all, that denial is not just a river in Egypt. It's what we do, and I see it in my direct family, my brothers, my cousins, absolutely. I saw it with my mother. My mother was diabetic, and my maternal grandmother was diabetic. And, in the old days, my grandmother used to say, oh, baby, I can't eat that. And I never understood why she'd say, oh, that, she's making these cakes and pies, but she would say, I can't eat that. I never saw her take an insulin shot or my mother at all. And both of them, I watched my uncles, 2 of them die from diabetes. And they were aware, cognizant, but I never saw treatment. I never saw an indication of doing anything about it. I say all that to say, in this diagnosis of prostate cancer, I'll never forget my brother, who's a year younger than me. I was back home in Oklahoma and telling him about this and the side effects of, I was, with the hormones. The side effect of the hormone treatment is hot flashes and sweating and things of that nature. And we're talking about the impact of that. And, the whole 9 yards about what was happening with my body. And he said to me, he looked straight to me in the face and said, I think I have it too. And I looked at him, I said, what do you mean you think you have it too? Have you gone to the doctor? Have you, what would make you think you have it? If you're going to the bathroom 7, 8 times a night or whatever the circumstance may be, if you're aware of it, what are you doing about it? And particularly when you're looking at me knowing that I have prostate cancer. But I wasn't, it's sad to say, I was not surprised by that because we live in a culture of denial that I don't want to know. I think if I know, it's going to make it worse. And I've seen that multiple times in family. Absolutely.
That thing there of, I don't want to know, right? I don't want to know. And it's easy for me to say, being a part of the industry, because my platform is to empower patients. Mm-hmm. I've worked in what we call the precision medicine industry, which is sequencing genes, leveraging the knowledge of our individual genetics to treat us as, patients, as individuals, to get better outcomes in diseases like cancer. So, genetics is spreading, but that's a real thing that a lot of patients and caregivers may not speak to, is that fear and hesitancy of knowing. From your experience as a journalist, even, can you speak to what that is and how do you get past it for good?
I just call it the psychosis of being immortal. and dealing with mortality. I just call it the psychosis of that people are more inclined to respond to medical treatment and care, if you will, a day late and a dollar short. After my sister, the things I learned about my sister were amazing to me. When they told us that she had stage 4 cancer of the colon, had to have a kidney removed, I'm thinking, how do we get there? And as I found out that she had been living in pain for quite some time, and had never really done anything about it, that she was taking 8 to 10 aspirin a day to mitigate the pain, and not understanding what those aspirin were also doing to her body as well. Those are the kinds of things that, the way I grew up, the environment I was in, that going to the doctor is trouble. Don't bring me no bad news, kind of thing. And I just call it the mortality, the psychosis of being mortal, that people would rather deal with it when they have to deal with it, as opposed to being ahead of the curve, preventative, understanding your body, understanding that, you have medical coverage, you're at the job, that's all right to go and look and see, as opposed to being worried about what they're going to find, because if it's hurting your body, it's going to be found.
Yeah. You just said something that I thought is really, really powerful. The lack of trust that Black and brown communities have with healthcare providers, historically, and it's not, unfounded. We know stories about Henrietta Lacks now, right? They made a movie about her life, the immortal life of Henrietta Lacks. And if it wasn't for her cells that are called HeLa cells, there would be no precision medicine industry, because her cells didn't die. They were immortal. They continue to replicate. And, Johns Hopkins, it's very well, it's very well publicized.
That's right.
But, even as a journalist, you've seen stories of all kinds. Can you speak to that lack of trust historically that, Black and brown communities may have in healthcare that might prevent them from going to the doctor, early detection of diseases like cancer, or getting the care that they need?
Well, number one, I think you hit on something that's very, very important and often overlooked. Is that part of the equation is that there's a trust factor there. And if there's a legacy of someone who doesn't give you a sense of empathy, of care, of concern, of value, and the only time you go is when there's trouble, that's how you build on that mistrust, that fear. When you see circumstances and situations of our legacy and history within what the medical community has done in terms of experimenting on people of color, absolutely, I understand that dynamic. You've heard people say, and I get it, that my mother used to say, "Oh, no. If once they open you up, you can forget it. It's, you're going to be, you'll never be right again." And where does that come from? That comes from someone in the legacy of seeing someone who didn't value and care about a loved one and that medical care that they were receiving, if you can even call it medical care. And that's been passed down. It's been handed down. My attitude about that is that was then, this is now. And more importantly, that you can find someone who's a reflection of you, your values, your culture, et cetera, et cetera. If that's important to you, we do all of this, every medical specialty that you can think of. And so if that's of value to you, I remember, I'm going to get off track here. I'll just tell you quickly an anecdotal story. In a newsroom with my colleagues in the newsroom. And when I worked in California, a young lady, we were all in the room together. And the young lady turned to a colleague, another female colleague, and she said, "My niece is looking for a gynecologist, but she wants the gynecologist to be a woman. Do you know anyone?" And the woman responded and says, "Yes, I know Dr. Jane Doe. And her number's 12345. And she's really good. But by the way, she's Black." I whipped my chair around and I said, "What did you just say?" And she didn't even realize I was in the room. And she goes, "Oh, no, some people want to know that." And I said, number one, it's it's not even it's horrifically racist. But number two, that woman didn't ask you if that's her own business. If she said, I want a white gynecologist, female gynecologist, that's not what she asked you.
Yeah.
You perpetuated that. And I think that's what we see a lot of times, is that the level of trust and reassurance is finding those people and to remind them that, yes, we come and a variety of people who have this skill set. And so many people, including my own family members, forget that. And so that level of trust is lost because they don't think people who look like you and I are doing those jobs of medical specialty.
Jeez. There's a lot there. Okay.
Right. I mean, I said I took you off that track, but I think part of that dynamic is when we ask the question, what I call mortal psychosis, your fear of what's going to happen to you at a place where you're supposed to get help. That's part of the dynamic. It's been handed down for generations. And at some point in time, we have to stop that.
Yeah. At any point in time when you were going through your diagnostic workups for prostate cancer, or by the time you got your second diagnosis of throat cancer, did anybody mention genetic testing or any type of diagnostic workup to find out what actual genetic link there is?
I don't recollect that. I think there were some suggestions about studies of some sort, if you wanted to be part of a study or something of that effect. But I don't recollect hearing the term genetic testing at all. I do believe that what was being provided in both circumstances were case studies based on age and et cetera, et cetera. Did you want to, or alternative treatments to whether it be the prostate cancer or the tonsil cancer? That's what I remember. I don't remember anybody looking at it from a genetic standpoint.
I'm careful to, when I'm talking to patients or people who know that I'm in the field and they naturally will ask questions, because I'm not a doctor, that this is not medical advice show. But what the purpose of Genetics for Healthcare podcast is to empower patients, to educate patients and their caregivers on the genetic implications of disease treatment, survivorship, screening for early detection, and in some cases, prevention. So let me share some stats about prostate cancer according to the National Cancer Institute. Prostate cancer is highly linked to inherited genetic factors. It reports that in upwards of 60% of prostate cancer risk is caused by heredity, which includes individual gene variations that we call mutations in the industry. And these mutations tend to cluster in families who share DNA. In such a family unit, if this is your history, this risk of developing prostate cancer and even breast and ovarian cancer is higher than the general population. So if you have a family history where your first or second degree relative has been diagnosed with cancer, a first degree relative would be like my mother or my sister, using myself as an example. A second degree would be a cousin or an uncle, right? Mm-hmm. If that's your family history, you can benefit from talking to a genetic counselor. Because, for instance, if you're a man whose mother or sister had breast cancer, you can still be in a high-risk category for developing prostate cancer. Likewise, if you're a woman whose father or even your uncle or your brother, they had prostate cancer, you might be at a higher risk for developing breast and ovarian cancer. Either way, you want to have these conversations with a doctor who may refer you to genetic counseling, or you can seek out genetic counseling on your own. There are labs who can connect you with genetic counselors virtually to do pretest counseling, to take your family history and to assess whether or not this might be paid for through your insurance, for instance. Also, talking of high risk, if you are of African ancestry, Black men are over 70%. Some studies exceed 100% more likely to develop prostate cancer than white men in your lifetime. So first of all, go to the doctor. Every year you should be going to the doctor. You should start having a PSA testing, which is a simple blood test as well as a digital rectal exam starting at 40. If you have family history and, being a Black man makes you of a higher risk for developing prostate cancer and other inherited cancers. And a lot of the risks are associated with things that are within your control. For instance, access to healthcare. If you have insurance, use it. Go to the doctor. Get your annual test. If you don't have insurance, there are, plans on the open market to make sure you have insurance when you need it. When something goes wrong and you have symptoms, well, use your insurance. Go to the doctor. And then we get into the area of, prevention, right? So if you talk to your doctors about your family history to make sure it's documented in your charts, and that may prompt more frequent screening workups that your insurance may cover to prevent a cancer diagnosis or detect it early, which is the key to long-term survival of a cancer diagnosis. One of the major factors that influence Black men having higher cancer rates at later stages that ultimately result in worse outcomes is just not being engaged in this type of conversation with your family or your healthcare provider. So just be willing to talk about it. Simple awareness can prevent you from developing disease. You can catch it early, which means you can have better outcomes, less invasive therapy. But even more so, it can prevent future generations of your family from having a cancer diagnosis. Even in the areas of treatment, genetic and genomic testing is having an increased role in treatment plans. There are drugs that are targeted to specific genetic mutations, such as PARP inhibitors or, in some cases, immunotherapy. And this information can also help optimize certain chemotherapy regimens. A lot of folks who have had family members or firsthand experience with cancer are familiar with chemotherapy. The difference between targeted therapy and chemotherapy, chemotherapy is kind of like, your buckshot spray, sawed-off shotgun shooting at your disease, whereas targeted therapy is more like a sniper. So genetic information can help your care providers be a lot more precise in the treatments that they're giving you. Even in the area of survivorship, which means those who may have been treated and cured and have no evidence of disease, or those who are going through therapy, there are genomic tests that can provide information that can help your doctors manage and monitor your prostate cancer. And that is called circulating tumor DNA or ctDNA. Another name, it's called MRD testing, which means minimal residual disease or molecular residual disease. You can Google those terms, but the point here is there's a number of doctors, whether it's primary care or specialists, who are not aware of these resources. And that's why this podcast exists, to empower you to have these conversations and get the answers that you want and you understand. You hear that siren?
Yeah, I did, but
Okay.
I'm a reporter. I'm used to it. It didn't faze me at all. You're all right.
True. So many cancer drugs in the pipeline are targeted therapies. They're going to target a specific gene aberration. We call them mutations. And with the historical nature of Black and brown patients not participating in clinical trials, we know that there are healthcare disparities in heart disease, diabetes. Black and brown patients tend to have worse outcomes, even in cancer, where, white Americans have a higher prevalence of cancer diagnosis. Black patients have poorer outcomes. So the point here is I want patients and caregivers to see, with the pipeline of drugs being created that are going to target the genes, the drugs of the future are going to be optimized to the genetics of those who participate in the clinical trials.
That's right. You can't win if you don't play.
from your perspective, and again, this is my perspective, this is why we're doing this. We're just trying to reach out and empower them to be better patients. But from your perspective, why should genetics matter to patients?
Well, I just believe that it's a roadmap. It is literally from my vantage point, a roadmap of letting you know what you're facing. When we look at people and say, "Oh yes, he looks just like your grandfather," that's called genetics. Oh, you sound just like Mima. That's genetics.
Yes.
So the concept of understanding that roadmap in terms of our empowering our health only makes logical sense. But again, we're talking about people who hear and see different things, who see it as, it's experimentation. And I don't need anybody experimenting on me. We've seen that movie and we know how it ends. There's reluctance.
Yeah.
I understand reluctance. I understand hesitancy. But I also know, as you just mentioned, what we see in terms of the real outcomes for us day in and day out. So what can we do to affect that change? And this may be the road we need to follow. Absolutely.
Yes. So from, the shoes that you sit in and the unique experience that you have, I always want to kind of end conversations by giving patients like 3 questions. You may have more, but questions that they can ask their care provider, their nurses, and even their family to help be a partner and, be a participant in their care to get better healthcare outcomes.
The questions I asked, I keep going back to the concept of a roadmap for your better health. The questions I asked are the questions I would suggest that people, particularly when something's wrong with you and someone gives you a diagnosis, I say, explain better. Please educate me. I don't know that terminology. What does that mean? What does the word mutation mean?
That is so freaking important. I'm sorry, I didn't want to. That is so important. Oh, man. Okay, sorry, Steve.
Right. No, but what I do for a living is I say to people all the time, okay, what does that mean in English? I know you are using acronyms and nomenclature in the world in which you operate, but you're talking about my well-being. So I said to my doctor, what does cancer do? Because we just assume everybody knows what cancer is.
That's right.
What does it look like? Can you show me a cancer mass? You've done a biopsy. I said to my doctor, and again, questions you can ask. I make a living asking questions, so I got to ask a million of them. When a doctor tells you have a 70% chance of survival over a 5-year period, I said, well, I want to live longer than 5 years. So what does that mean? Tell me what that means. So ask questions that come into your head every single day in your health environment. Don't be afraid to ask. There are no silly questions whatsoever, because all you're asking for, you're seeking information to help you understand, comprehend. Doctors aren't going to know everything. Of course, my wife did not care for my urologist. The reason why she didn't care for my urologist, because I loved him. He's a great guy, young urologist. He's from OU too, so we got along. But he would shrug his shoulders and say, I don't know. And she thought that was, incompetent. He goes, well, how does he? Because we're in a lane that he didn't know. And I appreciated that more than someone giving me some medical pablum of what the possibilities may be that I would never understand. I hope that answers your question about the questions you would ask, which are very simple and direct. Please tell me what I don't know in a manner in which I can know. That's the key.
That is so incredibly powerful. And we know that it can be overwhelming if you are the person at the center of this fight in whatever disease, in this case, cancer, that you're managing. So it can be hard to even think rationally, to even come up with those thoughts. But the care providers as well, your support group, your support team, whether that is family members or patient advocacy, groups. Somebody, I encourage you to get someone there who can ask these questions. And this is, your fight. This is your life. This is your health. So don't hesitate to stand up and ask those questions and make them give you answers that you truly understand.
Absolutely. There's no, because you are your best advocate, period. The doctor certainly is going to do presumably the best they can from a medical perspective to try to help and heal you. But as I tell everyone, I'm my own agent. I have to advocate for me. And if I don't, then you just become one of many on the caseload and you'll be forgotten. They're just looking at data. Help them remember you.
That is right. That is right. Well, I know that our guests are certainly going to remember you. And I can't thank you enough because, as you mentioned, at the top of the broadcast, that you're on the other end of this. You're used to answering the questions and telling the story, not being the story. So, man, I cannot thank you enough just for your candor, for sharing your experience for the benefit of our listeners.
Rome, I'm doing well. I'm happy to say I'm doing well. I'm going to stay down this road, and I just want people to know that they can do exactly the same regardless of the circumstances. And there was certainly a time when I said, why me? Because I've got 2 separate cancer diagnoses. But you know what? I'm all good. We're doing well.
Fantastic. Well, I can't hold the fact that you are a Sooner against you. My mother went to, graduated from UT. She's the first college graduate in our family. University of Texas Longhorns, for those who out there don't know UT. And I went to Mizzou. So right. We're kind of double negative with the
That's
Sooner.
Right. That's right. That's right. Absolutely. I won't hold that against you.
Right. Again, we're so privileged to have Steve Pickett, Emmy Award-winning broadcast journalist, on Genetics for Healthcare, a podcast for patients. Thank you for being with us, Steve.
Thank you.